Welcome, everyone. Welcome to our Grand Rounds. Nice to see everybody here from different disciplines. We have Mark Snowden, who's our Chief of Service, who's going to introduce our speaker.
Thank you, Sharon. It's my pleasure to introduce John Fortney. Dr. Fortney is a medical geographer and a health services researcher and professor in the Department of Psychiatry and Behavioral Sciences. He's also been appointed the director of the Division of Population Health. His work is focused on identifying and overcoming barriers to mental health care for rural populations using geographic information systems and a range of econometric techniques to help measure accessibility, utilization, and quality of health services. Recently, he has begun developing and disseminating telemedicine-based interventions to improve care for rural primary care patients, with a particular emphasis on the provision of team-based collaborative care within virtual clinical environments. His talk today is entitled Telepsychiatry and the Integration of Mental Health Services into Rural Primary Care Settings. So, welcome, John.
Thank you, Mark. I want to start off by talking a little bit about the new Division of Population Health. This division has been around since July 1st, and I've been the director of it for about 24 hours now. This is a research division, and it combines the research, evaluation, and implementation components of Dr. Caton's Division of Health Services and Psychiatric Epidemiology, and Dr. Unitzer's Division of Integrated Care and Public Health. Dr. Unitzer's division had both clinical research and education components. The clinical and education components have been moved to departmental level activities, and so the Division of Population Health just includes the research and implementation efforts of that previous division. But it also includes the AIM Center, of which Dr. Unitzer will remain the director. So what is population health? The kind of standard definition of population health is the health outcomes of a group of individuals, including the distribution of those outcomes within the group. The groups can be defined various ways. They can be geographic regions like nations or communities, in which case this overlaps a lot with public health. But this can also be employees, like all the employees at Boeing, which UW is now covering, racial and ethnic groups, people with disabilities, and patients enrolled in healthcare systems. And we're really taking this kind of more narrow focus in the division of and looking at the outcomes of patients enrolled in healthcare systems. So those enrolled in a health plan, those going to FQHCs, et cetera. We're not going to look at the health of communities or the social determinants of health, at least at this point. And this isn't really different than what's the type of research that was previously conducted in these two divisions. It's kind of just a rebranding. Though it is very different than what our colleagues are doing in intervention development and clinical trials that focus on improving the outcomes of patients who present for care. It is different than the way care has traditionally been provided, which is providers focus on the outcomes of patients that overcome all the barriers to care to present to their office for treatment. And it's more congruent with the way care is going to be provided in the future under these accountable care organizations, which are accountable to the outcomes of their enrolled populations and not just the patients that present for care. So it is congruent with the way care is going to be provided under health care reform. And this will be causing providers in the future to change a little bit how they provide. They're going to be thinking more about health promotion, coordination of care, and outreach, and less about the patient who's just in front of them now, and then the next one comes through and focus on them. So it is different than that. This is also congruent, this research focus is congruent with the new UW Medicine mission, which now states is to improve the health of the public by doing all the things that we do. But the focus here is on, again, the public or on population health. In fact, UW Medicine is now part of an accountable care network, so it's responsible for the health of enrolled patient population, not just the patients that present for care. In terms of psychiatry, so there's going to be performance measures that have this denominator. All patients with blank have to have these positive outcomes. In terms of psychiatry, an example of those performance measures will be all the patients screening positive for depression. That's a big denominator. What percentage of them have a 50% improvement in their PHQ-9 scores? Right now, I don't think that's very good, and we need to change the way we're delivering care to maximize that. First of all, we need to find what their PHQ-9 scores are down the road. We don't do that for the most part. We just screen and then don't reassess. So it's very much, the research we're doing is going to be very much congruent with the way UW is going to be providing care. So let's start off by looking at the population, the denominator. So this graphic, the big circle there is everybody with a mental health disorder. And based on the National Comorbidity Study replication that was done, of all the people with a mental health disorder, only about 40% get any kind of care whatsoever. That includes formal care as well as care from a spiritual advisor, etc., informal care. A third, 36%, get any formal care. So not very many people are presenting for care, showing up in the office. Even fewer, 22%, end up in front of a mental health specialist, and only 12% get to a psychiatrist. So the reach into this patient population, especially by psychiatrists, is very small. And for psychiatrists, if you want to make an impact on those population-level health, we're going to have to increase the size of that circle somehow, because you can't make a big difference if you only see 12% of your patients. From the population health perspective, what we're interested in is population-level effectiveness, which is the product of reach times effectiveness. And this is something that Doug Zachzik has written about. And reach is the proportion of individuals with a disorder who receive treatment, and effectiveness is the proportion of patients who receive treatment who are responding or remitting. And it's the product of those two things which determines the population-level health. And we have to develop treatments and interventions and models of care which maximize just not effectiveness, but the reach times the effectiveness. We've got to reach a lot of people, and we have to have a big impact on those we do reach. And this is difficult because in our field there is a shortage of mental health providers. There's been a nice study that looked at how many counties in the United States had unmet need with regard to psychiatrists. It's 96%. And the median level of unmet need is 74% in those counties. So given this shortage of mental health providers, we needed to develop models of care which maximize this population level effectiveness. So it's a tall order. So this graphic just is kind of a rubric which shows the different types of models of psychiatric care or mental health care. At the top, which is where most everybody works, is in the referral model. So that's where a primary care provider identifies a patient with a mental health problem, refers to a specialty mental health setting, and the patient goes there and gets treatment. And that's probably pretty effective treatment, but it reaches a very small amount of people. So you have here on the left side there, the further up you go, the more effective the care is, and the further down you go, the more people you reach. Collaborative care has probably come second on the list. It's probably not quite as effective as a referral, maybe as effective, but it certainly can reach more people because you can a psychiatrist can leverage their resources. They can work with their care manager and supervise them and see 4, 5, 6 patients an hour in terms of having an input on their outcomes versus one. Third would be the behavioral health consultant model, which is another model of integrated care, which is more of a co-located model where you have mental health specialists working in teams with primary care providers. A primary care provider identifies a problem, gives a warm handoff to the mental health provider. The mental health provider does a brief assessment and treatment. Probably not as effective because it's less intensive than collaborative care, but it reaches all those primary care patients that are coming in. Then we have the consultation liaison model, and then the curbside consultation model, where the provider, psychiatrist is seeing patients, and in the last, they're talking to the primary care providers about patients without seeing them. The evidence for these, there's good evidence that the psychiatry referral model is highly effective, but it doesn't reach very many people, 12% for psychiatry. Collaborative care also is very effective, 80 randomized trials that have shown that, and that has pretty good reach. The behavioral health consultant model, even though it's being adopted all over the country, has unknown effectiveness. There's been no RCTs of it, but people hypothesize that it's effective, and it has really good reach. The consultation liaison model could potentially have really good reach, but the evidence to date suggests that it's not really very effective. When Caton did a review back in the 90s of the consultation liaison trials, so if a patient comes in, they get randomized to seeing a psychiatrist who then provides a diagnosis and a treatment plan to the primary care provider. That appears to have no impact on outcomes compared to usual care. Another trial by Susan Hedrick here at the Puget Sound VA randomized patients to collaborative care or consultation liaison, and consultation liaison didn't do nearly as well as collaborative care. And then curbside consultation, I'm not aware of any trials of that, but it's unlikely to be effective, even though it could potentially reach a lot of patients. So we need to work on that. Let me turn now to rural, which is kind of my passion. This is a map of all the rural counties in the United States as designated by the OMB. And based on this definition, about 20% of Americans live in rural areas, or about 55 million people. And if you go back and look at that paper that identified counties with unmet psychiatric need, it's highly correlated with rurality and poverty, not surprising. So in rural area, do we not only have kind of, in the United States, we not only have a lack of capacity in mental health, we also have an inequitable distribution of resources. They're all in urban areas. So mental health resources are both scarce and inequitably distributed. We need to address both those problems. As a result, access to mental health is poor in rural areas. There's longer travel times to see mental health specialists, and that's associated with the lower likelihood of receiving mental health care and less intensive mental health care. There's also a cultural access problem. There's tight social networks in rural areas. You know relatively few people, but all those people know each other, and so if one person finds out something, everybody knows it. So when you seek mental health treatment, there's a lack of anonymity. There's probably greater stigma in rural areas. There's some evidence of that. There's emerging evidence that the stoicism and self-reliance of rural culture results in people not seeking treatment. And as a result, if you look at rural-urban differences in service use and quality, they're pretty pronounced. The National Comorbidity Study found that rural individuals with mental health disorders are less likely to receive any treatment, formal or informal. Analysis I did of the Medical Expenditure Panel survey data suggests that people with depression in rural areas are more likely to get pharmacotherapy and less likely to get psychotherapy than urban individuals, probably because they're going to primary care instead of specialty care. And that's actually proven in the National Comorbidity Study, which shows that rural individuals are less likely to get specialty mental health care than urban individuals, which is a major problem because the receipt of minimally adequate mental health care is greater in specialty mental health care settings than primary care settings, as you can imagine. It's about 13% of primary care patients will get minimally adequate mental health care in the primary care setting. And about, depending on the patient population, 15 to 45% of primary care patients will respond to treatment, depression treatment, and even fewer remit. So there's obviously a problem in rural America because they're going to primary care and the quality and outcomes of mental health care in the primary care setting is not very good. So given this epidemiology in rural America of mental health service use, you would think that collaborative care would be a very good solution, a promising solution, because it's focused on helping primary care providers. You guys invented collaborative care, so I'm not going to go into detail about what it is. I will say I'm going to call it practice-based collaborative care because the model that generally gets tested and implemented is one where the team is located in the primary care setting. It is measurement-based, so you're using things like the PHQ-9 to assess response to treatment. That makes it accountable for an accountable care organization, because then you can tell that organization, here's what X% of patients are getting better. It's team-based, so it's able to leverage scarce psychiatry resources to treat more patients than would normally done in a referral model. And it's population-based and patient-centered, so if patients aren't showing up for treatment, there's a lot of outreach that's going on. So it's focused on that denominator. There's a registry of patients with depression, and you're treating everybody in the registry, not just those that are showing up for care. So there's been 80 randomized controlled trials that show that it works. There's a lot of evidence for it. It's really well suited for large urban clinics where you can have full-time care managers that are dedicated to care management. You can have mental health specialists on site working with the whole team. It's not really very well suited to small rural primary care clinics. Here's some results we analyzed in post hoc from the QUEST trial of collaborative care, which recruited about half large urban primary care clinics and half small rural primary care clinics. And the small rural clinics didn't have any mental health specialists on site, and since they were in rural areas, they're not very available in the community. And as you can see over time, the blue line is the results in the urban clinics that are getting significantly better, and the patients randomized to collaborative care in the rural sites are flatlined. They're not getting any better. So this actually motivated a lot of what my research is to try to adapt the collaborative care model so it works better in these rural primary care sites. And I focused on using telepsychiatry to do that. And specifically, instead, we use telepsychiatry and other HIT technologies to adapt the collaborative care model to support rural primary care providers. IOM defines telemedicine as the use of electronic information and communication technologies to provide and support health care when distance separates the participants. It mitigates a lot of barriers to care for individuals in rural areas, obviously increases geographic access because you can provide specialty mental health care in the nearby primary care setting. It increases cultural access because you can provide those specialty services in the less stigmatizing primary care clinic. A patient could go into primary care, see a mental health specialist over interactive video, and nobody know their car was parked in the community mental health center. And you can potentially match patients with culturally or linguistically compatible mental health providers. A friend of mine, Jay Shore, does a lot of work with Native Americans, and he's had a lot of cultural competency with that group. There's been a lot of evidence that shows that telepsychiatry is equivalent to face-to-face care. Both patient and provider satisfaction is the same. Diagnostic reliability is the same. These have been determined through RCTs. Pharmacotherapy treatment's equivalent, and psychotherapy treatment is equivalent. However, almost all the telepsychiatry that gets delivered in the United States is specialty referral telepsychiatry. It's not integrated. So using that same rubric, what we have here is on the top of the pyramid where almost all the care is delivered is the telepsychiatry referral model. There's a potential for the telepsychiatry collaborative care model, which is what I'm going to talk about in a minute. And there is the potential for a telepsychiatry behavioral health consultant model, which sounds like an oxymoron. It's virtually co-located providers, so they're waiting by an interactive video unit or a PC with Skype on it, and the primary care provider identifies a patient, flips on their computer, and there's somebody that they can introduce the patient to, and they would kind of immediately, somewhat on-site, have access to that mental health provider. There's no evidence that that works either, though we're doing a trial in Little Rock, or in the VA in Little Rock about that. There's a RCT I left behind when I moved here. There is a lot of telepsychiatry consultation, and potentially you can do telepsychiatry curbside consultation. So what's the evidence for these models? As I said, the telepsychiatry referral model has been shown to be effective and potentially but the problem is it still is a low reach, right? You can have a psychiatrist in an urban area either seeing patients face-to-face for an hour at a time, or you can have that same psychiatrist see a patient in a rural area over interactive video an hour at a time. It's kind of a zero-sum game. You're not treating any more patients, but at least it's a little more equitable. Telepsychiatry collaborative care, I've done 3 trials, which I'm going to talk about in a minute. It is effective, and it has decent reach. The telepsychiatry behavioral health consultant model, I said we're doing a trial on that now in Little Rock. The telepsychiatry consultation liaison model does not appear to be very effective. Kathleen Myers has done a nice trial where she randomized kids to telepsychiatry consultation liaison versus telepsychiatry referral, and those that refer do much better than those under the CO model. And there's a really innovative model of telepsychiatry curbside consultation called Scan Echo that came out of the University of New Mexico, where specialists at University of New Mexico get online with rural primary care providers from around the state. One of those rural primary care providers presents a case to the specialist, and they do it then a lot with HIV. They can do it in psychiatry, various specialties, and they discuss that patient. There's a Q&A, and then but there's no evidence that that works, but that's a really innovative model. So what is the telepsychiatry collaborative care model? What we do in this is we have an off-site depression care team that involves an off-site nurse care manager supervised by an off-site psychiatrist. And in various trials, we've had other mental health specialists involved. We've usually had a pharmacist, but we've also had a psychologist on that team. And these have been university-based, and they provide kind of centralized support to multiple remote rural primary care providers. Care managers do all their work by telephone. We use interactive video for psychiatric consultations when the care manager and their supervisor thinks the psychiatrist needs to see the patient. We've also provided psychotherapy over interactive video. And then if we can, we use the electronic medical records for the team to communicate with the off-site primary care provider. So in the VA, we've done these trials. Psychiatrist writes a note, puts it into CPRS, has the primary care provider be a co-signer, and the primary care provider sees it. We also use web-based decision support systems to provide decision support to the care manager. We used a system that I developed called NetDSS, which I've sunsetted since I moved here, very similar to what you guys have here with the care management tracking system. Yeah?
So the care managers are also off-site?
Yeah, it's a little different than the way you guys do it, and I'll get to some evidence about that, what works better in that report. I think it could probably work either way. Yeah, the model here is to have the care manager on-site, but the psychiatrist off-site. We've tested something slightly different. I didn't know what you guys were doing when we were doing these trials, though. So here's kind of the picture of it. The patient's in the middle. They're working with the primary care provider face-to-face. You have the care manager who's talking with the patient on the phone. You have the care manager and the psychiatric consultant going into NetDSS or CMTS and looking at patients in the registry to see who they need to talk about. And then, if necessary, the psychiatric consultant actually meets with the patient if they're failing treatment or a complex patient. So let me talk about a couple trials we have done. The first one is the team study. This study was done before Wayne created his team study. This stands for Telemedicine Enhanced Antidepressant Management. This was done in the VA, and we wanted to compare the telepsychiatry collaborative care model to usual care in the VA. We did this in 4 states, Arkansas, Louisiana, Texas, 3 states. We did it in 7 community-based outpatient clinics, which are primary care clinics that the VA has. VA has now over 800 of these, and about half of veterans get their care in these community-based outpatient clinics. Screened a bunch of patients for depression with a PHQ-9. Enrolled about 400, excluding those who were already getting specialty mental health care, and followed them up at 6 and 12 months and did intent-to-treat analyses. We did provider education to all the primary care providers, and then usual care got really nothing beyond that. In the intervention arm, we had a care manager that would do telephone outreach to patients, help them with education and activation, help them self-management goals, assess their barriers to care and help them overcome those, monitor their symptoms over time, monitor their medications, adherence and side effects over time. If a patient wasn't doing well, we stepped up care by having a PharmD go into CPRS, check their medication history, and if necessary, call the patient and corroborate some of the information in there. And then we provide a medication recommendation to the primary care provider. If that trial failed, we had the patient come into the primary care clinic and actually see the psychiatrist, and then provided another recommendation based on that. So about 80% had major depression. These were a treatment-resistant group of patients. They on average had 3 prior depressive episodes. 2/3 had previously been treated for depression. 40% were currently being treated for depression and still were screening positive. We used a cutoff of 12 on the PHQ-9 for this study. Looking at SF-12 physical and mental health component summary scores, there are 2 standard deviations and 1.5 standard deviations below national mean. So there's a sick group of patients, 5.5 chronic illnesses. About 10% had panic disorder, about half had GAD, and about 25% had PTSD. So a fairly sick group of patients. As I said, we were really focused on antidepressant management in this trial, and we were able to increase patients' adherence to their antidepressants, odds ratio of about 2. And we're able to increase their response to 50% reduction in symptoms at 6 months and 12 months, significantly so at 6 months, odds ratio of about 2. And we're able to increase their remission rates significantly so at 12 months, with odds ratio about 2.4. You will notice these numbers are pretty darn small, though. The response and remission rates in the veteran population is much lower than it is in group health kind of environment, and probably UW as well. What am I doing on time? Kind of thinking about what the mechanism of action was for this trial. I think it was medication adherence. We were able to go into the VA's NICE administrative data and look at their pharmacy fills, and we used something called a medication possession ratio. So for the time period, we were able to figure out how many pills were mailed to them. The VA mails out medications to veterans. And so we knew how many antidepressant pills or daily dosages they had over the time period. And if you look at, so if it's, say it's 180 days, you figure out how many days they had pills, and you just calculate a ratio. So if that ratio is 50 or 50.5 or 50%, you know, they weren't really responding very well to treatment. But if it was up around 90%, they were doing really well. So I think we were able to improve outcomes by improving antidepressant usage here. I will say we did also look at a secondary qualitative and survey data about people's reasons why they weren't adherent to their medications, and it was pretty illuminating. You know, the reasons they weren't adherent because either they said they weren't working or there was a severe side effect. So medications weren't necessarily well received in this population. The next trial we did was in federally qualified health centers, and this kind of gets to your question. This is the outreach study, which I can never remember what that actually stands for. Outreach using telemedicine for rural enhanced access in community health. And what we wanted to do here was compare the telepsychiatry collaborative care model to a practice-based collaborative care model. In particular, we wanted to compare it to what HRSA was trying to get implemented in federally qualified health centers at the time. HRSA was really pushing, if you guys remember, the health disparities collaboratives, which were chronic care models for diabetes and hypertension, etc. They also had something they called the depression collaborative, which was trying to get FQHCs to uptake the chronic care model for depression. And it essentially involved a care manager following kind of the typical care manager protocol, and then trying to engage patients in specialty mental health care in the community. Half of FQHCs are in rural areas and therefore don't have any mental health specialist on site. There are mental health specialists available in the community, but access to them is very poor. But that's what they were trying to promote. So that's what we used as our comparison group in this case. So it's a nice comparison of the off-site care team, the telepsychiatry collaborative care intervention, to an on-site care manager. But in this case, the on-site care manager didn't have a psychiatric supervisor. They had to work with some mental health specialists in the community. We did a study in Arkansas FQHCs, and 8 of them, they all lacked mental health specialists. We screened a bunch of patients, enrolled about 340. We excluded very few patients who were seeing especially mental health providers already. We followed them up at 6, 12, 18 months. Did intent to treat analyses. So if you look at the intervention components here, the practice-based, we did provider education for all the providers. The practice-based, patients that got randomized to practice-based received care from a care manager who was a nurse on site there at the FQHC, and they did patient education activation, self-management, barriers assessment, monitored symptoms, monitored medication adherence and side effects. And then our telepsychiatry collaborative care model had those elements, except the care manager was located at the university. We also had a psychologist who was providing CBT, the only person who provided CBT in Arkansas. We had them on our team. We also had a pharmacist and a psychiatric consultant who supervised that team. And the care manager, in addition to doing medication adherence monitoring, also did the counseling adherence monitoring and tried to encourage patients to try CBT. You know, you may be thinking this is an unfair comparison. It would be obvious that the telepsychiatry would do better, but I think there was some equipoise here. Certainly the telepsychiatry group had the advantage that the care manager was full-time and dedicated to care management, whereas the care managers on site, we paid them half-time to do this. But if you're a nurse in a primary care clinic and you're told you're supposed to spend half your time doing proactive outreach and half your time doing reactive, put out a fire in the clinic, I need this now, it's hard to be proactive when you're having to be reactive all the time. The care manager in the telepsychiatry arm obviously had supervision from a psychiatrist, which was helpful. And it was probably easier for them to follow the protocol because they were kind of a tight-knit team. On the other hand, when our care manager called the patient up, I mean, the patient had signed a consent, but still it was, you know, hi, my name is blank, and I hear you're depressed, and I'm here to help you. So it's kind of a cold call, and so there's no therapeutic alliance that's there like you could have for the on-site care manager. The FQHCs had no electronic health record at this time, so we generated progress notes and faxed them and hoped that the primary care provider would see them, whereas the care managers on site could have kind of hallway discussions with their primary care provider. Mrs. Jones is getting worse. We need to do something. That wasn't possible. And the on-site care managers could kind of, in a more holistic way, integrate the mental health care they were discussing with the patient with their physical health care, and we weren't really able to do that. So I think there were some advantages and disadvantages to both models. It's really interesting that the characteristics of this FQHC sample is nearly identical to the characteristics of the VA sample except for gender. Again, over about 80% had major depression on the mini. They had 4 prior episodes instead of 3.7. 75% had prior depression treatment compared to 66%. 48% were currently being treated for depression and screening positive versus 41%. The SF-12 scores are about the same, very poor, about the same number of chronic health conditions. Panic disorder is about the same. A little more GAD in this group, 63%, a little bit less PTSD, 15%. I know this is a hard slide to read, but this, I think, is the mechanism of action in this trial, which was the ability to follow the care manager protocol between the two groups. So we went into the paper charts and did a chart review of all our patients. It's kind of a pain, but I think it was worth it. And this just shows kind of how many times the person doing the chart review is able to find a documented instance or progress note where these various elements of care management protocol were clearly done. So how often they found a note where they talked about educating and activating the patient. How many times they found a progress note where there was a PHQ-9 score, or evidence that they had documented medication adherence or side effects, etc. And you can see across the board the care manager in the telepsychiatry arm was able to have far more documented care manager activities than the on-site care managers. Especially if you look at the self-management one, in the first 6 months they were able to have 4 telephone calls with the patients where they discussed setting self-management goals, like engaging in pleasant activities, socializing, engaging in physical activity, whereas almost none of that was done in the practice-based care management arm. Antidepressant adherence was good in both groups, so no significant differences there. We did a lousy job engaging patients in cognitive behavioral therapy. About 20%, 17% I think, had attended 1 session, and I think it was less than 10% had 8 or more sessions. And partly because, and this was a learning experience for me, was that this was kind of a specialty encounter. I think the patients considered this a specialty encounter. It didn't happen when they were having a normal primary care visit. They had to come in specially. And what's worse is they had to become a medical center patient. So they were an FQHC patient. They had a patient number. To get CBT, they had to enroll in UAMS's healthcare system and get a new number. They had to do the Department of Psychiatry's intake form, which was ridiculously long and complicated, and mail that back. I think that was kind of seen separate and not very appealing to them. So that was a bust. However, we had outstanding treatment response rates in both 6, 12, and 18 months, and an odds ratio of 8. So they did much, much better. And you can see the outcomes for basically the same intervention are 3 or 4 times better than they were in the VA, despite everything except gender and veteran status being the same. Remission rates, actually the odds ratio of 12 on our remission rates, which were above 30%. And just shows the difference in depression severity scores. So my interpretation of this is that the mechanism of action was the frequent number of care manager contacts in the telepsychiatry group, and specifically the amount of self-management they were able to do with the patient. There was a nice paper that came out of the IMPACT trial that showed that patients that were engaged in self-management activities had better outcomes than those who weren't. So to kind of answer your question, I kind of think this off-site care manager, at least in this case, was able to do better than an on-site care manager. It may have been that it was due to having a psychiatric supervisor. If we had a psychiatric supervisor for the on-site, that it would have been equivalent. I don't know the answer to that. Greg Simon wrote an editorial on our paper that basically said that. Should have done that. Okay, so the last trial, or the most recent trial we've done was a collaborative care study, or telepsychiatry collaborative care study for PTSD. There are not very many collaborative care studies for PTSD. And so our objective was to compare telepsychiatry collaborative care to usual PTSD care in the VA. This one we did in four states, Arkansas, Louisiana, Texas, and California. 11 CBOCs that didn't have on-site mental health specialists. We recruited here with opt-out letters because the VA at that time was not screening for PTSD. They are now. And we slowly enrolled 265 patients with PTSD that weren't already getting specialty PTSD care and followed them up at 6 and 12 months. This trial was designed to dovetail with a trial that was currently being conducted, or previously being conducted, they weren't finished yet, by Paula Schnurr, who gave grand rounds in February. And she was testing a practice-based collaborative care model for PTSD, Respect PTSD was what it's called. And I fully expected her trial to be positive, and then we would come along and hopefully get similar outcomes, and we could say, look, telepsychiatry collaborative care is just as good as practice-based collaborative care for PTSD. That's not the way that it ended up, but that was kind of thinking at the time. So this is pretty much the same as before. Usual care got prescribed provider education. The CBOCs that we were in did have mid-level mental health specialists. A lot of them had social workers, and they were providing I guess what I'd call supportive counseling. They were certainly not providing trauma-focused, exposure-based PTSD treatment. They were doing some PTSD groups. They were doing some one-on-one supportive counseling that was not focused on PTSD, or it certainly wasn't exposure-based. And in fact, we did a chart review of that group after the study, and they were getting 12 psychotherapy sessions over the course of the year. Quite a lot. But they weren't getting any of the care management stuff. For those who were randomized to the intervention, they got the typical care management stuff, our pharmacist, and the psychotherapy we provided was cognitive processing therapy, and exposure-based psychotherapy that's been proven to be effective. In this case, the psychotherapy could be delivered within the same system of care. So they didn't have to sign up for a new system of care. So it was much more acceptable to the patients. And what worked really, really nicely was our care manager working with the psychologist to get the patient engaged in psychotherapy and to adhere to the session attendance and to do their homework, etc. They worked, they met once a week. We talked about patients that weren't doing what they're supposed to in terms of the homework or showing up, etc. It worked really, really nicely. In terms of the case mix, we used CAPS to verify the PTSD. It was an eligibility requirement. You have a question? Yeah.
I'm just wondering, so it seems like on the previous slide, towards the bottom, you had to progress through a number of steps.
Oh, yes.
And do you have a sense of what kind of patients required from the management, what kind of patients went on to get a psychiatric consult?
My memory on the medication management is sketchy. It's probably about 20% did that. So I'm not even confident about that. I can't remember. The psychiatric consultant, we had about 15% in both this study and the previous study that ended up seeing the psychiatrist over interactive video. That's a good question. And we waited for that until somebody failed the trial. Half of the patients, their main trauma was combat-related. Again, this is a treatment-resistant group. 80% had received PTSD treatment previously. SF-12 scores equally dismal. 4.5 chronic physical health conditions. Panic disorder, comorbidities much higher, 44%. GAD pretty high at 67%. And 80% or so had comorbid depression. So we actually were able to get a few more medications prescribed for the patients in the intervention group, mostly prazosin, but as a result they had worse adherence to their medications overall. So the green group there had non-significantly worse medication adherence because we were throwing more medications at them. I don't think medications were helping this group at all. I haven't looked at the data yet. I was about to before I moved. But these patients, we had a medication algorithm that we were using. So the team, after the medication history was done, we'd figure out where in the algorithm they were. They were always at the bottom of the algorithm. There was really nothing left to do. So there was not much to improve on their psychotherapy. However, we did a fantastic job of engaging them in cognitive processing therapy. We had over half attend at least one session, odds ratio of 18%, compared to those in the usual care group, which had to drive to the VA medical center to get this. On average, patients were 60 minutes away from the VA medical center. And we had, up 38% or so actually attend 8 sessions or more, which is kind of the therapeutic dosage that's needed, so odds ratio of 8. So the care manager, having the psychotherapist in the same system of care and the care manager working with the patient and working with the psychotherapist really worked out well in the study. And this shows the green line is the change in PTSD severity on the PDS, which is significantly lower at both 6 and 12 months than usual care. Interestingly, if you put in, they had 8 sessions or more of cognitive processing therapy in these regressions, it completely mediated the intervention effect. So the intervention effect was completely due to the receipt of psychotherapy. And this shows that we were able to improve depression scores as well. Now, by the time our results were available, Paula Schnurr's results had been published, and hers ended up being a negative trial. And the reason is that their trial focused on the pharmacotherapy optimization, and patients who they talked in or encouraged to get psychotherapy, they referred to the mental health service in the VA. So they kind of think of it as enhanced referral. And enhanced referral, it doesn't really work very well. People don't go, and then in some cases, I guess they went but got more supportive therapy. They didn't get the evidence-based psychotherapy. So it ended up being that our trial was positive while hers was negative, which completely surprised me when it happened. And I think it's all due to the fact that we had the psychotherapy component for this disorder. In fact, there's been 6 trials I know of collaborative care for PTSD. 2 of them aren't published yet, but 3 did not have a psychotherapy component and were negative. 3 had a psychotherapy component and were positive. So these 3 trials, kind of a quick interpretation of those, and I'll try to move along. So telepsychiatry collaborative care focused on pharmacotherapies, better than usual depression care. Psychotherapy collaborative care is superior to practice-based collaborative care if there's not a psychiatrist consultant. And telepsychiatry collaborative care focused on exposure-based therapy is superior to usual PTSD care. Now you'll notice I talked a lot about reach in the beginning, but none of these studies measured reach. This is just all effectiveness for those reached. In all these trials, our intervention was able to reach 95, 98% of the patients the care manager had contact with. Reach is really something that is best measured in an implementation trial. So now you've got this model, you try to implement it into routine care, and then the question becomes how many patients actually get it. It's expensive to measure both reach and effectiveness in an implementation trial, but that's kind of where you do it. So what are the future directions? The VA has an implementation science arm called QUERY, Quality Enhanced Research Initiative. They recently defunded all their centers and released a new RFA for new centers. And I was lucky enough to be able to get one of those centers funded. Funding starts October 1st. It's called the Virtual Specialty Care Query. The long title is Implementing and Evaluating Technology-Facilitated Clinical Interventions to Improve Access to High-Quality Specialty Care for Rural Veterans. It has 2 mental health projects embedded within it. One is Greg Rieger's that's focused on a smartphone app for prolonged exposure therapy. And one of the projects is mine, which is focused on the implementation of that top intervention for PTSD. We're going to do that in 6 CBOCs in Vermont, South Carolina, Iowa, Arkansas, California, and Washington, focused just on PTSD. We're actually comparing 2 different implementation strategies. That's kind of the first aim, typical VA way of implementing something. Here's an FTE, here's standard operating procedures and guidelines and some technical support and training versus more of an externally facilitated implementation, more like what the AIM Center does. And we also want to determine if the sites that successfully implemented this intervention, how many patients was it able to reach and how many patients was it able to improve their outcomes. We've also submitted a large pragmatic trial to PCORI, which we hear a funding decision on August 18th, any day now. And this is focused on, how far can you take collaborative care? Should patients with schizophrenia go into collaborative care instead of being referred to specialty mental health care? Probably not. What about bipolar disorder? So what we're doing is a comparative effectiveness trial of telepsychiatry collaborative care versus telepsychiatry referral for complex patients. So patients with bipolar disorder and PTSD. We're doing this in 15 federally qualified health centers in Arkansas, Michigan, and Washington. And I think there's some theoretically, these have clinical equipoise. The collaborative care model is probably going to have better reach. We're going to be able to reach more patients. The care manager is going to be able to reach more patients. The psychiatrist is going to be able to have input on more patients. But it might not be as effective for those patients reached as the telepsychiatry referral model would be. So the telepsychiatry referral model is probably more effective at treating bipolar disorder and PTSD than the primary care provider is, even with help. But probably the reach is going to be much lower. So the question is, how does the 2 products compare? And we're hypothesizing that the collaborative care model is going to do better because the reach will be so much higher. So last slide, going back to this issue of population level effectiveness that the new division is focusing on, the reach times the effectiveness. As I said, telepsychiatry referral model, which is almost how all telepsychiatry is done right now, does geographically redistribute specialty mental health services, and that increases equity, and that's a good thing. But it doesn't increase the capacity of psychiatrists and psychologists. It's a zero-sum game. It's just moving the shells around. The telepsychiatry collaborative care model increases both equity and potentially the capacity of mental health specialists. You know, the psychiatrist consultant can reach and touch many more patients than they could if they saw patients one at a time, and therefore may have the potential to have a bigger population level impact. So I think it would be better if the effectiveness of the telepsychiatry collaborative care model was, you know, at least non-inferior to the referral model, because then you can have a bigger impact on mental health. So I think I left a few minutes for questions, and there may be some typed in. Thank you. Yes.
I have a couple of questions. One was, how do you define rural? Rural county or rural
Saskatchewan
area?
Valley or Saskatchewan County.
The question is, how do you define rural? You can define rural any way you want to. There are about 25 federally definitions of rural. You can look at just population density or population size in a county. You can look at commuting patterns. And really, there are 25 different definitions that the federal government uses. So if you need to be rural, you can find a definition which categorizes you as rural. Some are based on counties, some are based on census tracts, some are based on zip codes. There's not a correct answer to that. And I will say that rural is not a boundary. Rural is kind of a multi-dimensional concept. It has to do about longer travel times, greater stigma, greater self-reliance and stoicism, lots of different things that make up rural culture. And it's not just, are you in a high-density or low-density population. But if you're looking for kind of a designation to make you eligible for something, there are lots of definitions you can use. The one I showed was the Office of Management and Budget.
And then I was curious if you know what the current coverage is under, I guess, isn't Medicare kind of the standard for what they cover as far as payments for telemedicine right now? Is that something that's hard to get covered?
Medicare does cover telepsychiatry. The rates are so low that nobody bothers with it. So very few psychiatrists especially will bother taking Medicare patients because the extra hassle and the low payments make it less profitable than just seeing a patient face-to-face. Medicaid varies from state to state. Some states reimburse for it. Some states don't. Some have special requirements, like it has to be a rural area, or their closest psychiatrist has to be 60 miles away, or there are lots of different rules for it. So that's hard to generalize on.
Oh, thank you.
Yes, Matt?
With respect to, I believe it was the teen study where there was this sort of discrepancy between care manager fidelity to the particular protocol model. Do you have a sense of, again, of what was driving that? Were there the panel of the patients the same, even though one was 0.5 FTE and the other was 1 FTE? What was
So the question is on the outreach study where we compared telepsychiatry collaborative care to practice-based collaborative care, why was the difference in the protocols so pronounced? The panel sizes were smaller for the on-site care managers. Basically randomized half of the patients to the 1 full-time care manager and the other half to the 8 half-time care managers. So they're much smaller. I think it had to do with, if you're a nurse in a primary care setting, you're busy, you're too busy to do proactive stuff ever. And I think Jürgen has that nice paper in the Journal of Public Health, American Journal of Public Health, which shows the number of care manager contacts over time before and after they did pay for performance. And it was not very good in the beginning. That lots of patients were never contacted or had a few contacts. When they started withholding some payments, unless a certain threshold had been achieved, a number of contacts, that went up. So you need some way to incentivize people to do proactive clinical work. And I think the way the payments are going to be in the future is bundled payments for episodes of care. It does that, I think. Yeah.
For the new trial that you're
the telepsychiatry collaborative care
Yep.
model versus like the referral.
Yep,
Are both arms going to have cognitive processing therapy options?
great question. So the telepsychiatry referral arm is going to have a cognitive processing therapy offered to patients. For the collaborative care model, I'm actually switching from the off-site care manager to the on-site care manager model to fit what's going on here in Washington. And we're going to have those care managers provide psychotherapy to the patients because the FQHCs tend not to have providers that are trained in cognitive processing therapy. And we don't think the nurses can necessarily provide cognitive processing therapy. So we're going to do behavioral activation with those patients. And we think that will help the patients with bipolar disorder in their depressed states. And we think, there's some recent evidence that behavioral activation can help with PTSD. And you kind of get a sneaky exposure because you have patients leave the house and go do things, and you can encourage them to do things they tend to avoid. And so we're thinking that will be helpful. And so there is some evidence from Washington that's helpful for veterans. Who knows? Okay, well, thank you very much. I appreciate your attention. So we're